Hello, this is Dr. Sadia Khan from Pakistan, doing PG Diploma from University of South Wales. Today I am going to talk about pheocromocytoma. Now let's start with the question. A 42-year-old woman presented to the accident and emergency department with sudden onset anxiety, palpitations and headache. On examination, she had blood pressure of 200 by 120, although the fundus examination did not show any papillary edema. What is the diagnosis? The diagnosis is pheocromocytoma. Let's talk about pheocromocytoma a bit. In normal individual, there are two kidneys and above it there's adrenal gland. Adrenal gland is responsible for producing a special type of protein we call as catecholamine or adrenaline. But if there is a growth above it, above the adrenal gland, too much of adrenaline released from adrenal gland and can cause various symptoms. Catecholamine secreting tumors that arise from chromaffin cells of adrenal medulla and sympathetic ganglia are referred to as pheochromocitomas and catecholamine secreting paragangliomas, extraadrenal pheochromocitoma. They occur in less than 1% of hypertensive patients and most of them are benign, by which I mean they are non-cancerous mostly. Usually develop in medulla of adrenal gland but can occur outside the adrenal gland. By which I mean that most of the patients who have this growth, they are in the adrenal gland, but in 90% they have the growth in the adrenal medulla, which is a part of adrenal gland. But in 10% of the patient, the growth can be outside the adrenal gland. So it is possibility that patient can have growth outside the adrenal gland as well. Epidemiology. Most of the catecholamine secreting tumors are sporadic and others can have positive family history. How they present, the clinical presentation is 50% are asymptomatic and other 50% can have classical triad, like 90% of the patient can have episodic headache and 60 to 70% of the patient can have sweating, tachycardia, approximately one half have paroxysmal hypertension, others have primary hypertension which was previously called as essential hypertension. Rarely patient can present with crisis which can have hypertension or hypotension, hyperthermia, altered sensorium and can affect multiple organs which can lead to multi-organ dysfunction. So if a patient who has diagnosed pheochromocitoma or even undiagnosed, they can land up in the emergency with such crisis. So we need to consider one of the diagnoses could be pheochromocitoma and we need to treat them accordingly. Less common symptoms include orthostatic hypotension, which means change of blood pressure during the postural change, visual disturbances, weight loss, increased frequency of their waterworks, increased thirst, constipation, increased sugar levels in the blood, and rarely secondary erythrocytosis due to overproduction of erythropoietin. There is a rule which we always apply in pheochromocitoma. We call it rule of 10. What's the importance of this rule? Actually, in 10% of the patient, it can be cancerous. In 10% of the patients, it can runs in the family. In 10%, it can be extraadrenal medulla. As I already discussed, that mostly the growth is in the adrenal medulla. But in 10%, it can be outside the adrenal medulla. In 10%, it can affect both of the adrenal gland. In 10%, it can also be associated with other endocrine cancers. In 10% of the cases, it is associated with stroke, and in 10%, it can also occur in the children. That's why this rule is very important and one should consider about it. Now, how we diagnose pheochromocitoma? History will be most important here. The patient can have the symptoms which we discussed above, like they can have hypertension, raised blood pressure, by which I mean they can have tachycardia, they can have sweating, they can have headache, they can have shakiness. So history will be most important. Then we will go for the physical examination. What other points which we'll consider? Symptomatic attacks can occur over the days or weeks or even years. They can have blood pressure changes with the posture or even in the emotional stress. As I already told you that these patients can have hypertension, so the complication of hypertension can occur. So complication in long-standing refractory hypertension can be visual disturbances, manifestation of heart disease like difficulty in breathing, or fluid buildup in the lungs which can cause pulmonary edema. Manifestation of kidney damage and can have deranged renal function test with albuminuria. Now we know that history will be most important. Then we will go for the physical examination. Then the next step will be blood test and then imaging. Diagnosis confirmed by biochemical confirmation of catecholamine hypersecretion, then imaging studies. What biochemical evaluation we will go for? We will go for 24-hour urinary fraction metanephrines and catecholamines or plasma fraction metanephrines drawn from indwelling cannula following 30 minutes of supine rest. Urinary vinyl mandelic acid. If serum metanephrines are more than 1.2 nanomole per liter, it should be considered as diagnostic. We can go for direct assay of catecholamine level in the blood, including epinephrine or norepinephrine. Now let's suppose we have done the biochemical testing and we found the hypersecretion of catecholamines in the blood or in the urine. Now we will go for the localization. We will localize the tumor, where exactly the tumor is, right? So we will go for the adenal or abdominal MRI or CT scan. As we know that 90% of cases the growth will be in adenal medulla, but in 10% it could be outside the adenal medulla. That's why we have to go for abdominal or MRI CT scan as well. But if CT scan or MRI is normal in presence of biochemical changes, then reconsider the diagnosis, and if it's still considered likely, then we will go for another scintigraphy. We call this meta-iodobenzyl guanidine, which should be done. And as I already told you that it runs in the family and histories will be the most important, and also we will go for the genetic testing. It's very important to go for genetic testing in these patients. That's why if a person who has such symptoms, who come up with these symptoms, we have to go for it. The mainstay treatment is surgery, adenectomy. But before it, alpha blocker should be given so that we can normalize the blood pressure. And when it becomes normal, then the beta blocker should be given, which can control the heart rate. These are the effects of raised catecholamine levels in the blood. So that's why it's very important first to control it, then go for the surgery. And when a person who is admitted for the surgery, and patient management is very important. Assessment of vitals are of utmost importance, including monitoring of the blood pressure, monitoring of the symptoms like headache, monitoring of the hyperglycemia means raised blood sugars, signs of hypermetabolism, hyperhidrosis means sweating, orthostatic blood pressure means change in blood pressure during posture change. The purpose of this presentation is to make you aware about pheocromocytoma, what pheocromocytoma is, how it presents, how can we diagnose it, and what are the treatment options for it. So if anyone among you who is having high blood pressure and it's very difficult to control on medication, it could be sign of pheocromocytoma. Such patient should be referred to the specialist for further testing. And also if someone who is having headaches, frequent episodic headaches, palpitations, tachycardia, flank pain, increased sweating, such patient also should be referred to the specialist and they will be under follow-up. Thank you everyone.